Welcome to another episode of the AOT Pod, a new podcast series tackling the key themes within the otolaryngology curriculum, hosted by myself, Josh Michaels, and Georgina Wellstead, with the support from the Association of Otolaryngologists in Training and the ENT UK Foundation. Today, I'm delighted to welcome to the show Ms Katrina Mason, a paediatric ENT consultant at Evelina Children's Hospital, having completed a higher surgical training in South Thames. Katrina is also the Associate Medical Director at Euphonia, a digital health company specializing in autonomous clinical conversations using artificial intelligence. Alongside her digital and clinical career, she is the editor for the Unofficial Guide to Surgery, a surgical textbook which has proactively sought to improve the representation of black and brown skin in medical textbooks, and was recently included in the Royal Society of Medicine's Tackling Inequalities Through Innovation and Entrepreneurship conference. So, without further ado, welcome Katrina. How are you today?
I'm good. Thank you for having me and well done for doing this podcast. It's a really nice resource for trainees coming up to a very intimidating time. So well done and thank you for having me.
That's very kind, thank you. And of course, thank you for coming on the show. So let's kick things off. When did you take the FRCS exam and what were you doing at the time to help you prepare best?
So I had to split my part A and part B, and I did it just after completing ST6. Obviously quite an intense, like book-based exam. Just I think my advice for that is just do the graft, read the books, read the past papers, go on the courses. And then the COVID pandemic hit, and they basically pulled a face-to-face event for the Part B. So we were essentially one of, I think, the first cohort to have Part B during the pandemic, which meant we were the first people not to have patients. And we had to do it in the way that I think is now how it's done now, essentially very much vignette based.
So of course with the COVID pandemic plus your surgical training years, that's already quite a lot on your plate, but from what we were discussing before the podcast recording, you also did a master's at the same time. So with all of these different aspects of your career, both academically and surgically, there was clearly lots of stress and things that were getting in the way of preparing effectively. How did you combat that, and what were the things that you did to really accelerate your learning and studying at a crucial time of training?
So I think it's just a sort of mental headspace that this is a really lean in part of your training, and that it's very hard to do other stuff around it. So I think you really need to dedicate like your evenings, your weekends, and your daytime time to just focusing on the exam, and you kind of have to cut back on everything else. I think it's incredibly hard if you do have a family and young children, because ultimately I think there's this like narrow bit of just get the graph done. I think the key thing for part B was I had a really nice little group of trainees at the same stage as me. And it wasn't just like my friends from South Thames, so we had a KSS and a North Thames trainee, and we just twice a week made sure that we did a Zoom call and just fired questions at each other. And then it was just pulling in favors. So every boss that you've worked with, just say, can I have 30 minutes of your time? And these are the questions, you give them the questions and then just practice it, practice it, practice it.
Yeah, I think that's great advice, and actually speaking to other trainees and having that breadth of discussion beyond just your normal deanery really allows you to understand what caveats of information and knowledge gets passed on within certain areas of the country that you might not necessarily get access to. So really good advice there, thank you.
So one thing that I did was this process called neurolinguistic programming, which essentially is a little bit like therapy, but also hypnotherapy. And so I just had one session with a guy that I've been to before, and I'll try and dig out the contact details, who we just sort of sat down and talked about the mental process of going through this exam and visualizing what it would look like. And essentially, so in my head, I'd already done the exam and passed the exam. So when I came to do the exam, it was less intimidating and scary. And that's like, it costs, I don't know, 100 quid or something for a couple of hours. It's really nice, like a very left field thing to do for a very intimidating one-off event.
I mean, that's just a really great concept, isn't it? And it makes total sense that there's a mindset towards achieving success beyond just the knowledge to do so. And of course, with all that said and done, you take the exam, you pass. How did you celebrate?
Oh, it's a huge moment. It's huge because it's this sort of thing that's been in the back of your mind, I think, throughout the whole of training. It's this big hurdle. And it's this moment where you sort of feel like you've joined the club, and everyone sort of gives you that that level of sort of respect, and they give you a big hug or a handshake.
Yes, of course. I mean, when the consultants know that you've passed, it really does change things, I suppose, when you're working alongside them. And congratulations for the success that I hope many of our listeners will be looking to emulate very soon. But of course, we're here today to discuss this week's theme, which is Laryngomalacia. And I'd like to present to you a case of a 4-month-old paediatric patient referred to our local ENT department. They've come in with noisy breathing. I'd like you to please assess this patient, taking a focus history, detailing your differentials, and of course, identifying the relevant clinical details and appropriate investigations that you would like to carry out.
Okay, so I think the first thing to say is that noisy breathing is really common and one of the commonest things that we'll see in pediatric ENT populations. Um, and it's quite nice to broadly classify that as either being stertor, which is a sort of upper airway snoring type sound, or stridor, which is often a monophonic sort of squeakier sound. So stertor is classically the supralaryngeal obstruction, and I often make that sound to parents or patients, the sort of upper sound, and then stridor is predominantly from lower airway pathologies in terms of supraglottis, glottis, or subglottis, or trachea, more of a type sound. So then you think about the differentials. So if you're looking at stridor, as we've talked about, it can be dependent on the level of obstruction. So inspiratory stridor is classically a sound that's produced from the glottis or the supraglottic structures. Biphasic is often heard at the level of the glottis or just below in the subglottic area, and a more expiratory stridor, a bit like asthma, has an expiratory wheeze that's lower down in the chest. So it's mainly in the thoracic trachea, or it can be in the distal bronchi with Malacia there. Obviously, you've got a 4-month-old. It's quite a little person, so you need to really think about the urgency of how you're assessing this child, and obviously the context of where you are. And that's very much, you have to think about how distressed the child is looking in front of you, how severe their noisy breathing is, and how it's affecting them in terms of their ability to feed and grow and develop. So I think if we're looking at a 4-month-old, the commonest cause of an inspiratory stridor in that age group is going to be laryngomalacia, which essentially is a congenitally floppy larynx, which indraws on inspiration as opposed to staying open. So you get that sound as it draws in. And that can occur just in isolation, or it can actually occur with other airway pathologies. So that's why it's always important to think in the background, is there anything else that's going on? Or is this actually not the diagnosis, and is this another congenital airway pathology? So other congenital airway pathologies that we will often see are things like a laryngeal web, a laryngeal cleft, laryngeal cysts. Common, either concurrent or in isolation, is reflux disease causing edema of the supraglottis. Rarely, but not infrequent, we can see as subglottic hemangiomas, and often vocal cord palsies, which are either bilateral or unilateral and can be acquired through post-surgical iatrogenic injuries, normally from cardiothoracic interventions. Rarely in this age group, but always something to bear in mind in a new stridor is an inhaled foreign body. So with that in mind, you obviously have to do a really focused history and examination, and you use the adjuncts that we've got available to us. And for this case, it would be a paediatric nose endoscope. So to start with a history, onset, duration, progression. When did it start? How has it progressed? Is there anything that makes it better or worse, particularly if the child is very active and upset or excitable? Does that make the noisy breathing worse? Really importantly, with an infant of this age group, how is it impacting their feeding and their weight gain? Are they able to suck, swallow, breathe at the same time, or are they having to fall off the breast, taking a long time to feed, and actually they're really struggling with their weight gain, i.e., is the child failing to thrive because they're struggling so much with their breathing? So it's really important that you look in clinic at growth charts. So every child should, and every parent who's been given a baby also gets given a red book. So you would look at the red book in clinic, and at the back of it would have their growth chart that's plotted on. Sometimes on computer systems they're all digitized now, but I tend to look at both. And the really key thing you're looking at is crossing centiles, going down in a centile, obviously for them to thrive. Sometimes a baby is born on a certain centile, it takes a few weeks to find its appropriate centile, but it's when it's found it and then falling off, that's the worry, or has never found it and just falls off. So then you know, picturing this baby, noisy breathing, maybe failing to thrive, just step back a bit and look a little bit more holistically at the baby. particularly in terms of are they showing that they're really struggling with their work, what we call a worker breathing, and that is the accessory muscles to help them essentially indraw air. So you're looking at tracheal tug, subcostal or sternal recession, and it's really key to also ask about any worrying signs such as cyanotic events or any resuscitation events at home. Also sensible, again, thinking holistically, asking about recurrent chest infections, thinking about aspiration, reflux symptoms, which can be associated with concurrent, and the birth history. So that's really critical. Is this a term baby? Did they go to special care, neonatal care? Did they have respiratory distress at birth? Did they have non-invasive ventilatory support, or were they even intubated? Obviously, an intubation increases your risk of airway pathology, normally from acquired things such as subglottic stenosis. Increased risk, obviously, the more they've been intubated, the longer they've been intubated. So generally, ex-premies are at risk of that. There's also some conditions that are associated with airway pathologies, common syndromes, Down syndrome, 22qs, but lots of other syndromes. Talked about prematurity, that's obviously a key risk factor for airway pathology. And obviously any child that's had cardiac surgery, particularly PDA ligation, the left recurrent laryngeal nerve anatomically loops under the ductus. So when it gets ablated, it can easily be not truly ligated, but bruised. And then you often get a resultant left cord palsy following cardiac procedures. Cutaneous skin lesions, we're particularly thinking about hemangiomas, which particularly if they're affecting the face and the beard distribution, but actually can occur in isolation or anywhere. And then I think the other things just to check for is if you're now thinking about inhaled foreign bodies as a choking event with cyanosis. To complete everything, really sensible to do developmental assessment. So is this baby developing normally? So at this age, you might be thinking holding head, potentially starting to roll. If they're not doing that, is there anything neurologically underlying? Family history, social history, drug history, allergy status. And then I would move on to a complete examination, which is a full head, neck, ENT examination, but specifically finishing with dynamic airway assessment with paediatric nasal endoscopy.
Thanks so much, Katrina. Now, talk to us when you would perform this examination and what it would entail.
You're kind of doing that in the consultation, some of this, by the way, obviously you've got a child in front of you, but take a moment to stop and look at this baby and listen. So you're listening for that sound. Can you hear it? Is it an intermittent sound? Is it there or not there? Get close to the baby, put your ear and take the clothes off. So you really need to look at the chest of the baby and really pay attention, obviously, to those accessory muscles to see if there's anything in clinic that you're seeing. If you haven't already brought that out from the history, it's not already obvious. Also look for perioral cyanosis, look for softer signs of syndromes that perhaps haven't been identified, and the general tone of the baby in terms of a hypotonic baby. Looking closer at the face, you're looking at opposite retrognathia, like the Chiara-Van sequence, where their tongue can be pushed back, which can give up airway sounds. Then a bit more focused, I then look in the mouth, looking for cleft palate or missed cleft palate, which can happen. Any obvious oral masses, any massive sort of issue with the tongue. Sometimes you can get little cysts, looking for that. And then looking at the front of the nose, looking at nasal patency, which you can use a metal speculum for. A thing that I really like is a really, really cheap stethoscope. So the basic ones you often find on the research trolleys, and you take the end off it. And so you've got this little tube and you can pop that under a nostril and really hear nasal patency. That's another top tip for any sort of tube, see if it's blocked or not. So trachea, pediatric trachea, NPA, just take the end off a stethoscope and listen. It's amazing what you can hear. Then you need to have a look, and we should all be trained to do that. I'm afraid there's no excuses. Really important you have an assistant when doing pediatric nasal endoscopy, and that's primarily for someone to help hold the baby, but also someone who you're going to be very focused looking down. You need someone who's got a bit more situational awareness, looking at SATS monitor. And even though we do lots of pediatric nasal endoscopies without SATS monitoring, I think it's just really sensible for an exam to say you're going to do this with saturation monitoring. Essentially, you wrap the baby up like little burritos. Their arms, they generally sit on the parent facing away from you as if the parent is the chair. Really important to talk nicely with the parent at this point because it's really stressful and scary, and you're going to make the baby's noisy breathing worse. So it's important to say to a parent, if they're not comfortable, they can sit out, but equally lots of parents sit in and say this is a quick examination, 30 seconds to a minute. The baby's going to be upset, but it will be over quickly. And I often say to mums or dads, just talk to your baby and let them know that you're here, and that helps keep them nice and calm. Your assistant basically helps hold the baby's head. So you go in, a pediatric nose endoscope ideal, but in 4 months old, sometimes we can get away with a 4 millimeter scope. You can decongest the nose with a bit of Otrivin, safe to use in babies, licensed to 6, but we use it all the time at the Evelina. So I'm happy for you to put Otrivin in a baby's nose just to open things up. Always sensible to look in both sides, make sure you're not missing any unusual nasal pathologies, check the choana, check the adenoid pad, and then you're really looking at the larynx. So when I'm looking at larynx, I'm looking at the tongue base, the position of the epiglottis, is it pushed back, is it retroverted? And then you're looking for your classic signs of laryngomalacia, which are the omega shape, the tightly curled epiglottis, the ariepiglottic folds, which are tight, and sometimes the arytenoids prolapse in on inspiration. A classic sign that you see in laryngomalacia is you can't see the vocal cords because the larynx is so tight. So if you're like, oh, I couldn't see the vocal cords, probably laryngomalacia because it's just so tight. If you can see the vocal cords, obviously just give it enough time so you can see proper movement. You can obviously try and look for other airway pathology. Occasionally, some people say they can look into the subglottis, but that can be really hard. And I think if you don't see anything at that point, but you've got a stridorless baby, then you kind of need to look down and do GA with MLB.
Really nicely described, thank you. So on examination, you find that flexible nose endoscopy reveals a tightly rolled epiglottis, and during your history you identify that there is failure to thrive, an inspiratory stridor, and this stridor improves on crying. What is your working diagnosis? Explain the pathophysiology, and what management options are available for this patient.
Sure. Okay. So that's the classic laryngomalacia, which is the most common condition I would be expecting in this age group. It's often a self-limiting condition, so it will present the first few weeks. I've often actually present the first few days. Now I've been doing this a lot more, and something's been not quite right from day one. It gets worse before it gets better, particularly as the baby grows, the airflow gets more. Generally, all have resolved by 2 years of age. So it's normally self-limiting and doesn't actually need aggressive management, but you do need to not miss those babies who do need surgical management. But what causes it? So we don't really know, but I think it's a combination of structural immaturity of the laryngeal cartilages. So they're just naturally a bit floppier, they're not as robust and strong, a bit like most of a baby. And so when they breathe in, it indraws, a bit like we call it the unfurled flower that naturally opens with time. So it's just still a bit unfurled, immature, and combined with a bit of hypotonia. And it's that classic inspiratory high pitch type sound. So as I said, it's normally a self-limiting condition, but it can be quite scary for parents. So part of the thing is reassurance. As I said, most children don't need intervention. Depending on the child and the time that you've seen them, sometimes very simple things such as starting on anti-reflux medication, because due to that negative pressure, you can get stomach acid drawn in, which causes edema, which makes it worse, or they just go hand in hand. So we tend to start omeprazole in our trust, and we generally tend to continue it until the baby's weaning. So it's generally stopped by about one year of age. Then you can obviously, if they've got associated swallow pathologies, get your SLT in, your speech and language therapist. They might need thickeners if there's concern about unsafe swallow. The ones who need intervention are those children that are crossing the centile, failing to thrive, or having airway events before they even get to the failure to thrive point. And at that point, essentially obligated that you need to look down under general anaesthetic, and that's with either DTLB, direct tracheal laryngeal bronchoscopy, or what I always call an MLB microlaryngeal bronchoscopy. Depending on where you train, it's called something different. But essentially, it's a direct dynamic airway assessment on a self-ventilating child and anaesthetic. It's a diagnostic and a therapeutic intervention. So what you would be doing is essentially you need to rule out other airway pathologies when you're doing when you're listing a child for that. And then the main surgery that we're doing is something called supraglottoplasty, which is just a generalized term for operating on or changing the supraglottis.
What are the surgical considerations when performing supraglottoplasty, and what features would you see intraoperatively in the patients that you do operate on?
Sure. So generally, there's no hard and fast rule about what you have to do, and it needs to be on a sort of patient by patient basis. And generally, we are on the side of caution with all laryngeal surgeries because you can't undo what you've done. So we're using Boucher instruments under suspension with a microscope, or combination of actually putting the endoscope in and having four-handed operations. So it's done with a surgical assistant. What you normally do is divide the ariepiglottic folds, so that tightness then opens up. And then with a dynamic assessment, so the patient's still breathing, you then see, is there prolapsing of the arytenoid mucosa? Does that need to be trimmed at this point? If you do, you can do one side or both sides, but I think the key is you need to preserve that interarytenoid area so that you don't get supralaryngeal stenosis and scarring down of the airway. So some people often perform it around an ET tube because they know that that interarytenoid area is protected. For ones where the epiglottis is really like clamping shut over the glottis, I have never done it myself, but I've seen and heard that you can sometimes rough up both the lingual surface of the epiglottis and the base of the tongue, and sometimes put a stitch in to help hold it open. And then obviously the final thing with anyone with a difficult airway is you've always got tracheostomy available to you for extreme laryngomalacia, which either is inaccessible from a very anterior larynx and you just can't get the instruments in. They're still having airway events.
Thank you very much. And that concludes our episode on laryngomalacia. Today we covered the scenario of a 4-month-old baby with inspiratory noisy breathing. We spoke about the potential causes, the investigations, appropriate examination and management of these cases. We spoke about the surgical steps and the key findings that you might see intraoperatively. And of course we spoke about the need not to treat and the self-limiting nature that laryngomalacia often is associated with. Katrina, thank you very much for being on the episode with us. Do you have any concluding remarks?
Hey, just good luck. Find your little crew, practice, practice, practice. And if you need a bit of mental support, neurolinguistic programming.
Yes, absolutely. I mean, I'm definitely going to remember that. And a big thank you to our listeners. We all appreciate you tuning into the AOT pod. Please stay tuned for more episodes that come out regularly. And of course, be sure to hit subscribe, leave us a review, and sign up to the AOT via our website, aotent.org. Thanks very much, and see you next time.